Welcome. Thank you for coming to our winter 2019 VCSQI meeting. Thanks for coming out to the lovely Boar's Head on a nice December day here. We've got an action-packed agenda this evening, so without further ado, I'll introduce our group's vice chair and upcoming chairman in 2020, Dr. Robert Shor. Dr. Shor?
Thank you very much. It's really a pleasure to see everybody here, and this is just fabulous. My responsibility right now is just to give you an update on the board meeting. Among the highlights, VHI, which is a way of assessing outpatient cost in addition to the inpatient cost with ARMIS, we felt was foundational to our ability to look at the cardiology piece, because so many of the procedures are done as outpatients. And we are very close to that. We've given approval to go ahead with the first set of download of data. Also, Eddie and Cherie have created a wonderful accomplishments for 2019 and 2020 goals piece of an effort to really put pen to paper along with our, in line with our mission and our vision and our goals. We are also pleased to say that we're getting closer with actually getting TVT in ARMIS and to really launch that piece of it, which is critical as the world of cardiology has evolved from more siloed to a really collaboration and hard team approach. So that's fantastic. We continue to grow from a member standpoint, and we have a number of institutions that are in process. We have 18 centers that are with the CathPCI uploaded to ARMIS, and that accounts for about 70% of the PCI that's done in the state. So most of the large centers we've got engaged, and we are working diligently, and Sherry is working, knocking on doors, trying to get those other centers to get involved. And hopefully, for a few I know, there's got to be a critical mass, at which point the other groups will get, or centers will get involved. So that's a quick highlight of the board meeting, and I will pass this back. Are there any questions about that, by the way, or any comments any of the other board members want to make? If not, then I will pass this back to Eddie for now.
Great, thanks, Dr. Shor. And just before we pass it to our evening presenters, I just wanted to call your attention to our VCSQI strategic plan, which has been in development this year. Our mission is to continuously transform cardiovascular care to improve patient outcomes and value. And hopefully, based on our collaborative meetings tonight and the discussions that follow, we will continue to follow that mission. And we'll also plan on circulating the goals list that Dr. Shor mentioned at the board level as well to all of you, just so you can have your input on where we're going, because at the end of the day, this is ultimately your organization. So with that said, our agenda tonight is focused on research, on 30-day readmissions, and then on some data review. So first, we have Dr. Robert Hawkins from UVA. He will provide an update on the recent research progress of the organization. Robert? And there are CMEs available. There are handouts, and we'll follow up with you guys on those as well.
Good evening. I'm one of the cardiothoracic surgery fellows at the University of Virginia. I've been part of the research committee here at VCSQI for a number of years, and was asked to give an update. 2019 has been a pretty busy year for us, a number of new projects and a whole bunch of publications that have come out. Just talking briefly about a representative sample of some of the ones that are currently going through the publication process. So the first one was just presented down in Florida, and we looked at minimally invasive versus conventional sternotomy for coronary bypass grafting. There is pretty limited data, particularly from multi-institutional sources. There are a number of single institution or single surgeon studies that have looked at this. But there are a number of issues raised, whether that's related to increased resource utilization or increased risk for postoperative complications. So we looked at VCSQI. Between 2012 and 2019, there were 26,000 isolated CABG cases. And then we had a pre-matched cohort of about that same number. There were 139 minimally invasive coronary cases compared to 26,000 sternotomy cases, so obviously quite skewed. So we propensity matched 2-to-1, came up with our cohort of 139 coronary cases and 278 open CABG cases. And what you can see is that the outcomes were pretty similar. Mortality was the same statistically. Complications, maybe morbidity, were the same. But we start to see there are some potential benefits with minimally invasive. Fewer blood transfusions, shorter length of stay, shorter ventilatory time, and actually decreased cost, which was different than what we were hypothesizing. So, this is a small sample size. Not many people are doing minimally invasive CABG in the state. But what we can find is that for those that are, there are similar outcomes and potential improvements in terms of resource utilization. Another one that we're looking at relates to concomitant atrial fibrillation ablation during mitral valve surgery. So this was a large randomized trial that found that there is benefits for concomitant atrial fibrillation ablation at the time of mitral valve surgery. It's a Class 1A recommendation. So we hypothesized that with the outcomes from these trials and the new classification as a 1A recommendation, that we would see increasing implementation of ablation. Of the 7,000 mitral valve operations in the state between 2011 and 2018, we queried this from VCSQI. We then, obviously, a few exclusions, and then we also subset it out by different types of atrial fibrillation and different types of mitral valve procedures. What we found was not what we predicted, similar to the last study. We found that, if anything, rates of concomitant AFib ablation are slightly decreasing. We also see that there may be a relationship by surgeon volume, and so higher volume surgeons may have a higher rate of concomitant ablation, although lower volume surgeons have higher variability across them. This goes into what surgeons are looking at in terms of who they do an ablation on and other factors that go into it. And so, despite increasing evidence and society recommendations, there's persistent underutilization of concomitant AFib ablation across the state, and that applies to both high and low volume centers. There's significant variability, and so this is an opportunity for improvement. Finally, we are just starting this project, and we're looking at the burden of tricuspid regurgitation in patients undergoing coronary artery bypass grafting. So we know that tricuspid regurgitation is associated with poor outcomes after valve surgery. And because of that, there is strong recommendations to repair TR at the time of a left-sided valve operation. However, there's not very good data when you're doing coronary bypass and aren't inside the heart. So we wanted to see if the same effects of TR apply to CABG patients. There were now 28,000 patients that we pulled from VCSQI. We stratified this by presence and severity of TR, and then in addition, concurrency of tricuspid intervention. So what we see is that there is not a ton, but some TR in CABG. So the incidence isn't as high in patients who have other valve disease. But with increasing tricuspid regurgitation, there is much worse outcomes after CABG. This isn't surprising, but it's useful to put into context. So, for example, the risk of mortality in a patient without tricuspid regurgitation is 1.6%, compared with severe TR, where it's 11%. And what we found is that for patients with severe TR, those that do not have a tricuspid intervention have higher rates of major morbidity. And while not statistically significant, there is maybe, if we had higher numbers, a difference in mortality. So for major morbidity, 40% in patients with severe TR and no intervention, and 19% with severe TR and an intervention. And then for mortality, it's 12% versus 7%. Obviously, these are low numbers, and over time, I think we'll get a better sense of the impact of both TR as well as intervention, whether or not there's a short-term benefit with this. So this is a very busy slide, but just a quick update. I've already realized one that I've left off from 2018, but we had a number of publications that came out in 2018, and then here is a list of everything so far that's come out in 2019. We have a number that are also under review, and then a number that we're about to submit for publication as well. Happy to take any questions. Obviously, that's a lot of different research that's going on.
All right. Thank you, Robert. And so continuing our theme of research, next I'd like to introduce Dr. Scott Barnett from Inova. Dr. Barnett will overview a 30-day readmission risk model that they've recently validated and published on.
Hopefully I get a better response than Dr. Hawkins did.
We'll tie this together.
Yeah, we'll tie it together. All right, thanks, Eddie. Okay, so one quick ground rule. I'm going to throw a lot of stuff at you. Feel free to stop me and ask questions. It's not going to bother me at all. The Inova table, no. And the over-under for how many times I point at the screen, that you can see my thumb on the monitor, so I apologize in advance. So this paper started about 2 years ago when Linda Halpin said, can we replicate a paper that came out of Hawkins? So this is how this was born. And then one of the surgeons said, hey, can we build a better mousetrap? So that's how discharge location got added. And then because one of the benefits to our data set that we don't take advantage of is we have cross data, which not many people do. So we can always sort of look at the penalties for some of these events. So what we did is this paper came out in 2017 from Hopkins by Killick et al. And he's actually published about 7 papers on this now, where he's just tried to use their data set to build prediction models. It's actually very common now. It's pretty easy to do. And so we just sought to do this with our data, and can we beat it? Can we basically be a better model? So what he did is he's got 5,000 patients, median age 61, 60% male, 50% isolated CABG, and they were randomly divided into 3-in-1 training and validation cohorts. And that's kind of the standard way to do this now. We didn't do it for our paper, but it's pretty much the standard. Multivariate regression, because he's doing a prediction equation. In the outcome, they were trying to build a risk score model that clinicians could use. All right? So here are our hypotheses. They're very simple. First of all, could we replicate it? Does discharge location influence the score? And then what is the influence on that score if we replicated it on the model? Okay? So we've got almost 20,000 patients, and you can see who I threw out. And this is the penalty whenever you hear a statistician like me talk about the penalty of missing data. If you look at the bottom right of the first line, I had to throw out almost 5% of our data, which was our targeted outcome, because I didn't have readmission data on those patients. So that's the penalty. Our sample size would have been 21,000, which is still pretty good. It's still 2014 to 2017, and obviously it's our data. So I'm going to confuse you a little bit more now, because I'm going to go back and forth between saying Model 1 and Model 2, Hawkins or VCSQI. Model 1 is always Hawkins. Okay, so I tried to highlight it in blue and red, but even I confuse myself sometimes. Model 2 is always the same parameters as the Hopkins model. Remember, I'm not trying to build a new model, I'm just trying to beat their model. So we start with the foundation that their model is the gold standard, okay? And then the last thing we did, we used logistic regression because it's a binary outcome, readmissions, yes, no. And then we use a linear mixed modeling for cost because we have to model the adjustment and the variation among centers. And this is key, and I'll highlight this a couple times because it comes up over and over. So, simple hierarchical linear model with logistic regression. For the non-statisticians, all that word hierarchical means is I'm trying to adjust for all the 19 hospitals. I'm trying to control for your intra-hospital variation. And depending on what data set I analyze, sometimes it's a 4% variation. The biggest I've seen is 14%. So before I even look at the model, the hospitals sometimes are adding 14% variation just by being different hospitals. So you always have to control for that. So at the end of the day, we created a risk score, and then I put them in 3 buckets for clinical utility. And I've left it on the probability scale, but it's essentially 0 to 1%, 10 to 13%, and then 13% plus. Low, moderate, and high. Because at the end of the day, I don't want the clinicians to remember 7.5 is what. I would prefer you remember low, moderate, or high, okay? Discharge location. This is a little confusing because the STS collects 6 different levels of discharge location. So what I did is my choices were home or other, because home represents about 75 to 80% of the discharge location, but instead we created 4 buckets. So we created home, extended care, home, hospice, and nursing home. Because this presents a pretty neat gradation of post-discharge care, okay? And again, all of these things are up for debate, so at some point we have to make these decisions. So cost is the same thing, it's just a linear mixed model. I control for the variation with the hospitals. Because we have so much variation in cost, I log transform the data to remove, this will be on the exam later, the heteroskedasticity. It's getting nerdy now. Yeah. The heteroskedasticity of the data, which basically means I'm just compressing the data so the variation is the same. And then I back calculate it. And whenever you guys see a random effects term in the paper, it basically means I'm assuming that every hospital has its own natural true median or true mean. When you see other terms like fixed effect, it assumes the state of Virginia has a true mean. I'm not sure that's appropriate. The random effects model is always more conservative. So as you're reading the literature and they throw that at you, and I know most of you skip that section that I write for you, the stats section, which is okay, you're not hurting my feelings. It's okay, I skip your results section usually and get right to your tables and figures. It's okay, it happens to all of us. So basically, it's about being a little bit more conservative than you normally would like. So here's what we have. So almost 20,000, 68% male, 81% Caucasian, 50% isolated cabbage. If you remember the earlier slide, almost identical to the kill it group. So basically, the first take-home message is that the VCSQI in this window of time is roughly the same as the Hopkins window. So the patients across the state lines at this point, at least in the databases, are fairly comparable, which means we could do this for other projects too, starting off the bat. Length of stay, 8 days, discharge location. Here's the 77% home, 17% extended care. In a perfect world, I would probably go back and make these a binary, home versus other, because these are 2 dominant terms, but hindsight's 20/20. So the Killick readmission score was 2.4, plus or minus 3.2, the variation. Ours was 2.8. Now, your first guess is, ooh, we're higher. Well, I added discharge location, so it's gonna be higher. Okay, so the model's roughly the same, but it's gonna be higher just because I added another term. I know you can't read this, but the left side is the logistic regression results for the Hopkins group in blue. The right side is ours. These are the terms that Killick et al. Predetermined for their model. Again, not building a new model, I'm testing their model, so we're starting with their model. The take-home message is, and you'll see, again, I keep pointing to my screen like you can see it. So what you can see on the left side of the screen is all the blanks for discharge location for the Hawkins group because they didn't have discharge location in the model. We did. Now, for the non-statisticians in the room, the really neat thing from this slide is the left columns and the right columns are the exact same data points. The reason there's a difference from right to left is simply by adding discharge location to any model. So if you look at type of operation and insurance, all of that variation between left and right is due simply to adding discharge location, which goes to show that insurance should probably be controlled in a lot of our models. And a lot of the things that we think about, insurance and discharge location. So I thought that was one of those neat little nuggets that you find in the data. Okay? And then you can see home is extended care is a significant predictor of 30-day readmission. So clearly where you go after discharge is a huge predictor of coming back. Okay? And I'll show you some cost data with that later. So the left column represents the point scoring that Killick allocated. Again, I didn't change these. These are his. So he allocated 6 points for severe chronic disease, 3 for African American, et cetera, all the way down for a 20-point score. All I did was add in red on the bottom, discharge location. I added 2 points for whether you went home or nursing home. So I've only added 2 points to the model. That's basically it. Okay? Everybody loves ROC curves. So everybody wants one for Christmas. Right? Everybody knows how to interpret these?
Oh, yeah, yeah.
Wow, the Inova group. Who doesn't know how to interpret these? Well, okay, anyway. These curves stink. So I'll tell you right now, the Killick group and our group stink. And I'll tell you why. In a perfect ROC model, you want the graphs to hug the left axis, the y-axis, and then make a hard right turn at the top. That means you've got super high sensitivity and low false positive rate. Okay? The line in the middle, the little semi-dots going left to right diagonally, that's the line of a coin flip. That's 50-50. Look how close both curves are to 50-50. It's not very good. So their model's not very good, but I beat it by 1/10 of 1%. So their curve, their area under the curve is 59%, ours is 60%. So what those numbers basically mean is if you randomly selected one case out of the next, one patient out of the next population, you'd have 59% chance to be a 30-day readmission. Ours is 60%. Not very good. So his model's not very good. Our model's not very good. The only good news is we validated his model. Okay? So, which is good for him because we used a different data set and a different test, but it's still not great. So here we give you probabilistic curves so you can see how the curves go. Now basically on the x-axis on the bottom is the point allocation from the models. The left side, the y-axis, is the predicted probability for each patient, and then I've bucketed them in bins for the scores. You can see our curves have a slightly steeper, but for all intents and purposes, based on this graph, they're the same. Ours just goes a little higher. Why? Because I added 2 points to the scale, to the survey. Okay? So here's the distribution of risk score, and here's where the results start to diverge a little bit. The left side is the Hawkins model, the right side is our model. There's virtually no difference in the low score. You notice how the moderate and high patients are exchanged. So the patients that we lose from the moderate group, they pick up in the high group. So this is where you start to see some separation by adding discharge location. That at this end of the scale, the concept of discharge location added to the model starts to put people, it sort of tips them over the line from moderate to high. Okay? So now we look at cost. Everybody loves cost data for the accountants in the room. You can see from left to right, low, moderate, high, low, moderate, high. Again, these are the same patients with different risk models applied to them. You can see the escalation of costs. So let's go down to second row, extended care. You can see the penalty for being sent home to sent to extended care versus, say, discharge home. I mean, the cost differential is it's a $20,000 bump in pay from low to high versus $27,000 from home, but it's still $20,000 delta. Does that make sense? So there's a huge cost penalty for sending patients home. Now, the interesting thing is I didn't tell you anything just then that you didn't already know, but now you can see it in like, empirical data, okay? So this is the unadjusted risk model, and so what I've done is I put it in a graphical presentation of what you just saw on the table to show you the sort of the contrast. The green represents the high group, and you can see how quickly the costs escalate as you go from low to high, right? So this is the normalized graph where I basically try to put it back on the log scale to remove some of those outlier data, because we have some patients that have incredibly high costs. We have some patients that have incredibly low costs. And I know the algorithm that we use to create the buckets has some, it can potentially do that, but I try to adjust for it at the other end. So this graph looks a little bit, I would say that it's a little bit more compressed from top to bottom. Okay? So our conclusions are, we've got 2 large studies, one involving a statewide database, ours, with 20,000 patients, and we confirm the existence of a 30-day risk model. Okay? All the other terms that he provided in his model, race, chronic lung disease, insurance payer, et cetera, were still continuous successful predictors of 30-day readmission. His terms that he picked predict readmission in our data set. So it's like for like. Both risk models suggest a near doubling of hospital costs. And that's probably the biggest take-home message for the whole group, is that sending patients to extended care and they come back, we're looking at least a doubling of costs. Okay? The results suggest a 30-day readmission is multifactorial. A quick note, when I tried to build a better mousetrap here, we have so much data in the VCSQI, I ran thousands of models. And the really neat thing is you can write a code to just spool through. Our patients are so different, they're so heterogeneous, nothing popped out, even with our sample size. So it's just, there's so many different reasons why patients come back, and a lot of it is probably not in our database, so I can't test it. But for the next person who comes along and tries to do this, it's going to be an interesting exercise, because there's just not much stuff that pops out. So a lot of these things are not modifiable, but, and here's where I need help, I don't know how patients get discharged to extended care versus home versus any other type. So this is where we can actually make them modifiable. We can't change race, we can't change age, we can't change type of operation, but we can possibly modify. And for the larger hospitals, or perhaps the smaller hospitals that have larger readmission rates, if you just multiply it by a factor of 20,000, that's sort of the penalty for sending them. That's just a median. That's not even accounting the high and low. And lastly, let me leave you with a friend I met in the Bahamas last year who photobombed me. It was actually only about a 6-foot shark, but he came closer than this monitor, and it's a little scary. So, any questions? I know I went through that fast with a lot of data. Yes, ma'am.
No, it's a real comment.
Where are you from? What's your name?
Anyway, I'm Liza. I'm a physician assistant at Inova. And interesting about the rehab, because in our institution, our physical therapists are the ones who determine which patients need to go to acute rehab usually. So usually when patients are medically ready, obviously they're either discharged home, or if they're not physically ready, they go to acute rehab. But we're starting as of, what, the 10th, Linda? The move in the tube, which is the like the new sternal precautions. Right. I don't know if anyone's heard of that, but and our physical therapists came to talk to us, and they think that with that, we're actually going to be able to send a much higher percentage of patients home instead of having to send them to rehab, because we'll let them use their arms a lot more than we have in the past. So just wondering that.
It'll be interesting to look at in 6 months,
right,
because
yeah.
I think those cost savings will be amazing. So, any other questions?
On the cost, when the charge is the same, will they compare?
How so?
Like,
Oh, I don't have cost data for him.
okay, you see what I'm saying?
Yeah.
If you've got 2 different charge masters.
Yeah. So one of the limitations for using our data is the algorithm we put the cost through to sort of normalize it to the state of Virginia or the Commonwealth, right? So because I need you guys to unblind your data, which I know is an issue that's not going to happen, especially tonight. But that way we could sort of build in the algorithms. Oh, that's a Centauro, that's a Roanoke, that's an Inova. As it stands now, once it runs through the chart thing, I just get one number.
Okay.
So that's a small limitation. What I always push back to reviewers is, well, what's your cost data say?
Yeah.
Oh, I don't have any cost data. I'm like,
Sure.
yeah. So at least we make an effort. Oh, I'm sorry.
Did you try to clean out the variables from Hawkins predictive model? Because if they had, whether it's sunny or cloudy on a day of dismissal, it would lower their sensitivity or their model to 0.58 instead of 0.59.
So the short answer is yes and no. So the first pass was using his exact model, and you can see the results. Everything that he predicted as significant, we predicted as significant. So our results are very similar. And then when I run, and I was taught never to use stepwise regression because you're letting the computer do the math for you. You're not using your judgment. But with our sample size, it's kind of fun to let the computer spool and find what it finds. The same stuff pops out, and then nothing else pops out. There's just not a lot. Even though we have a huge volume, we still have rare rates of comorbidities or post-op events. So those things just don't show up. In a perfect world, I could probably propensity match, but I don't like propensity matching because you throw away data, at least if you do it correctly. So I don't know if I answered your question, but you threw me with the sunny and shady. We talk.
I have a quick question.
Yes.
You've talked about a lot of data while they're hospitalized, trying to separate. How about if they participate in rehab or not?
I'm actually not sure we have that in our data set.
Because that
would be
speaks to
huge.
post-care
Yep.
and really can make a potential difference.
Do we capture? I don't think we.
If they do cardiac rehab, I don't think
No.
so.
we
And the
don't
timing of
know
rehab
who
would be amazing.
Did it.
Well, we have that data.
Is it in yours?
And you
CathPCI
can,
has it, but.
you can talk to Carla.
Carla has.
Carla has that data.
That would be interesting to look at. I didn't know we had it.
We could probably match it.
Yeah, that's,
Yeah.
and if I remember, we had like 35% of the surgeries go to rehab and a lower percent of the heart failure and stuff.
I know our rehab team would love to hear that.
Across all of Nova Hospital.
And that's something we can talk offline about looking at first.
Eddie, you want me to run the rest? It's like-
If you want.
I feel like you should cue the orchestra music and just pull me off the stage.
Well, thank you, Scott. Thank you, Robert, as well. I mean, I think these are both compelling exposés of the research, the great research the VCSQI members have done, utilizing our data sets. I'll say two things on that. First is, this is a democratic process. You guys are all welcome to join our research committee, regardless of if you understood any of the tests Scott was talking about or not. You're welcome to listen in. You're welcome to join in the conversations. This is your data. So it's yours to use. Secondly, is we want to democratize the process of disseminating this information. So all the slides will be on the website. We'll even do targeted site visits and calls with you all to review the publications if you'd like. And that's a project Sherry and I are working on for next year. So stay tuned, and more good stuff to come from the research team. So next up, we'll continue the theme of 30-day readmissions, and shifting gears a little bit more to focus on a cardiology standpoint, acute MI, heart failure patients, and other cardiology readmissions. So I want to invite up actually our two cardiology board members, Dr. Kontos and Dr. Shor, to form a little panel here. These will be a number of slides as well as some group dialogue, so feel free to chime in with your questions. Cardiology, we haven't really had a true quality initiative for our cardiology side of things yet, so this could be a first one, but let's see kind of what the data shows, and we can take it from there. Dr. Kontos?
So let's see. So I'm going to talk very briefly. And we'll have plenty of time for questions. It's supposed to be a very interactive session here. Just briefly about our Navigator program. It's focused on MI and primarily on heart failure patients, just to give you an experience what we've gone through. And I think this would be a jumping off point to see what other institutions are doing for their two different patient populations. And then I have just a few slides on what the national experience has been on readmissions, just to kind of give you a quick overview and also kind of set the stage for where we may end up going in the future. I'm clearly not an expert in this field, and most of the information we have came from our heart failure program, and it's mostly some preliminary data. Just to kind of give you a quick overview of our heart failure services at our institution, we actually participated in the first Navigator program for acute MI and heart failure with the ACC's program. And so much of this data was initiated through the grants we received from them to actually fund our navigators. So we have a fairly large program, heart failure, almost 4,300 visits, and we have a fairly active heart transplant program as well as a mechanical device program as well, with both LVADs and total artificial hearts. It's actually a little strange after a while. When I come home from work and explain we had 2 patients with TAHs, my wife was trying to figure out why we were dealing with OB patients or OB-GYN patients, and I completely forgot what else TAH stood for other than total artificial heart. And our patients are cared for in a number of different areas. We have actually a separate transplant service, mechanical heart failure service. Many of our more sicker heart failure patients are admitted to our general cardiology service, which is our ACE service. And I think like many other institutions, we find about half of our heart failure patients are actually managed just on our internal medicine services. We have a fairly large outpatient program as well. The program's evolved over time. Initially, we started with our inpatient navigator program with medication, appointment, and symptom review. This was initiated with 2 FTEs for inpatient navigators. They started out with face-to-face education, medication cards for the patients, binders on educational items for them. In many cases, we try to provide them with scales to take home, protocols for health management at home. And then we actually have a transition clinic in which patients are followed up within 1 week after hospital discharge. This is both for our heart failure patients as well as our acute MI patients. We did have some teaching in an educational venue, but this was dropped after a while because it didn't appear to add any value to overall reduction in readmissions or patient education. This is the navigator role, again, screening, consultation, education, and discharge through the course of admission. We don't have a specific heart failure pharmacist or dietitian. These are done on an ad hoc basis, and most of the diet education is done by the navigator. And again, at the time of discharge, they work on coordinating the patient getting home as well as scheduling their follow-up clinic visit within 1 week, as well as a 72-hour phone call. How do we re-stratify them? Well, we're actually able to use an EMR can be your friend. It can be shocking, and we've actually been able to use it for a couple of these different tools. One is we have a daily list that's generated every day. Excuse me, one of the things my daughter brought home for Thanksgiving was her cold from JMU. But we generate a list in which the EMR identifies patients who have BNP greater than 100, EF, systolic dysfunction defined as an EF less than 45%, and have received a diuretic and a chest x-ray within 12 hours. Patients who have 2 of those are identified for further screening. And then we actually have additional high-risk criteria here that identify patients who should actually be evaluated by our inpatient heart failure service. They meet the screening criteria above. They also have a low EF, a markedly elevated BNP, as well as abnormal vital signs or other high-risk findings such as a recent heart failure admission within 90 days and an elevated sodium. So it's kind of a 2-stage screening process to identify those patients. And it helps us to identify those patients who are actually admitted to a medicine service rather than a cardiology service. Overall analysis of our initial case mix showed that the majority of patients were actually heart failure, with about a quarter of them having acute MI as part of the Navigator program, and then 17% following the other cohort. Overall, about half the patients showed up to the follow-up for heart failure, and about 2/3 for the acute MI patients. This kind of just shows you the overall heart failure encounters versus the number of patients that were seen versus unseen over that time period. And it's been fairly constant with a pretty good variation over the first couple years of the program, 2016 and 17. Readmission rate actually was reduced. This is not risk-adjusted data, but just shows overall cohorts of patients who were seen. And there's been a consistent decrease, a lower readmission rate across, if we look at the time span from anywhere from 2 days out to the 30-day readmission for those patients in whom were seen by the navigator versus those who were not seen. And then overall, this accounts for over 900 patients who were seen and almost a little bit over 1,700 total patients admitted with the heart failure over that time span. And this resulted in overall patients who were not seen had about a 33% likelihood of being readmitted, significantly higher than those who were seen. And this has helped to drive some initiatives and requests for additional navigators to help in this program, because it does appear to actually provide an advantage. In contrast, it was a little interesting. We didn't find a reduction in our MI readmission rate. Part of this may have been related to the no-show rate. The readmission rate was about the same, 9 versus 10% for the two different cohorts. And as a result of this, to try to consolidate resources, because as many institutions, I'm sure all of you have the same problem, where the amount of funding you have is somewhat limited, to focus on the highest risk population, those with heart failure, particularly those in which the program seemed to make a difference. They pulled the navigators from the inpatient MI part of the program and pushed them over to heart failure. And the thought was that they would be able to identify and provide more education, particularly for those patients who were admitted to the non-heart failure services, the general medicine services, where we were missing. We didn't just give up on the MI patients. What happened is that for the at least those who are on the floor, and at least in our hospital, the vast majority of MI patients are cared for in a cardiology service. All the discharge education was transferred over to nursing as their responsibility, with the navigators providing guidance and specific documents for those individual patients. They still continue to provide the education for our CICU discharges. At least in our hospital, we have a constant bed crunch, and it's not uncommon for patients to be discharged home from our CCU. In fact, last year we had about 250 discharges directly from home. And with the ability to do this, it's actually allowed us to increase our outpatient APP capacity to provide more volume. What we've tried to do, at least for our MI patients, although we don't have a specific in-house navigator program, what we're trying to do is push for both our house staff, fellows, and attending to identify that most patients who come in, at least in our hospital, will be discharged in 2 days. It's typically 2 nights, 3 days. And what we try to do is identify them when they first come in, and let the patient know this is when you're going to be going home, so long as they don't have any complications, and to allow them to start planning who's going to pick them up, how are they going to get home, and let them know that they're not going to be in the hospital for a prolonged period, so it's not a surprise that at 8 in the morning you come in and round and say, oh yes, you're going home at 10 a.m. This helps us to identify patients' insurance needs. I think about half our patients are Medicare, about a quarter are private payer, and maybe a quarter to a third are either Medicaid or no pay. So obviously, with many of the medications can be fairly expensive. So we place an initial social work consult to get them evaluated for costs. For the CCU, for the CICU patients, the navigator will meet them when we put a consult in and provide the education. And all these patients are scheduled for an outpatient evaluation with an APP within 7 days after admission. This provides a transition for 1 to 2 visits for those patients, who are then subsequently transferred to a cardiologist for long-term management. I'll skip through that slide. This kind of shows you where we've increased our overall navigator programs, where we've actually, at this point in October of 2018, added a second outpatient navigator. One of the advantages of this is that we've demonstrated some reduction in readmissions, and our goal is to actually translate this program from an episodic care visit, but providing additional APP support, particularly for the heart failure patients, now provide a continuity clinic. So most of those patients would see a heart failure physician 1 to 2 times per year, and if they are clinically stable, they would be evaluated by an APP and allow the heart failure cardiologist to focus on the sicker of the overall patients. Just to transition a little bit to more kind of general cardiology and other readmissions, it's kind of interesting when you look at when people are readmitted to the hospital. One would think it'd be almost a continuous relationship. This is data for us for over a 1-year time period when we actually analyzed when they came home. And it was actually somewhat surprising that 1 in 6 of these patients came back within 3 days, and about a quarter, a little bit over a quarter, a little bit less than a third, or 31%, actually were readmitted within 1 week. And one can imagine that perhaps there likely are things we could have done on the inpatient stay that would have identified these patients who are not going to bounce back that quickly. And the majority of the patients were actually admitted within 2 weeks. And at least for us, we're trying to look at the data a little more carefully. One wonders, particularly on a cardiology service, maybe you would have benefit from having a multidisciplinary approach to these patients that have multiple different medical issues to identify those that, although we fixed the cardiology issue, they may have some other underlying medical issues that are going to lead to their readmissions. What we found is somewhat comparable to this data from this hospital that looked at their data for over a 3-year period with over 3,000 admissions. What they found was kind of they plotted out whether patients were readmitted related to the initial MI or other cardiovascular causes here and then non-cardiovascular causes here. And you can see a difference in overall causes for readmission as well as the timing of readmission. And clearly, I think for those patients who are being discharged from MI, focusing on them, identifying issues early maybe offer benefit. But again, providing more long-term continuity care for some of these patients, particularly if they don't have a primary care physician, may be important to avoid these long-term readmissions. When one actually looks at the causes for readmission, it's also interesting that unfortunately CMS doesn't care if they are readmitted for a cardiology cause or non-cardiology cause, even if they're discharged from a cardiology service. This was data from about 30,000 patients from the Action Registry from a few years ago. And they broke down patients into 3 different groups. Those in whom the readmission diagnosis was similar to the index hospitalization, about 1 in 5 patients, and you can see the diagnoses here, MI, chest pain, and ischemic coronary disease. Those that had readmissions that were potential sequela of the index readmission, for example, heart failure, arrhythmia, or complications, and this was about 1 1/3 of the patients, but almost 1 1/2 of the patients were readmitted for a non-cardiology cause. Again, kind of getting back to the point that we maybe need to focus more on a multidisciplinary approach to these patients when they're discharged, because why they're coming back is not necessarily going to be related to their acute admission. And then just one quick transition slide. I think many of you have heard about the new CMS voluntary value-based program where they're doing bundled care payments, and essentially they take the specific DRG, bundle it into, give you one payment that covers all the costs from the initial hospitalization through the 90 days of the readmission. This is important, trying to figure out how this would work for individual hospitals. And when you get down into the nitty-gritty of DRGs, it's interesting. Most of your MI patients don't fall into a true MI DRG. They fall into a PCI DRG. And it's only those patients who are not revascularized that fall into this MI DRG. Obviously, when you think about it, who doesn't get revascularized? It's typically going to be the older, sicker patient who's likely going to have a higher readmission rate. And when you start looking at this, the readmission rates are actually substantial, at least for the MI patients. It's about 1 1/4 who are readmitted at 30 days, but when you extend that out to 90 days, it's about 45% of patients, up to 48%. So it's almost 1 in 2. So you're looking at significant numbers of readmissions in those types of patients. And again, I think if hospitals that are able to take advantage of a multidisciplinary team approach to this are likely to be able to be the ones that are going to be able to better address costs and outcomes. Obviously, not a very simple way, not a simple population to look at, given the overall age and comorbidities of these different patients. So that's just kind of a quick overview, at least where we are in our program. And it'd be interesting to see how other hospitals are doing, what you're doing to reduce your readmissions. I think we're all trying to figure out what the best way forward is, and I'm not sure there's any one right answer to for any particular hospital. It's all going to be institutional dependent. Bob, I'll let you add some additional comments, and you have some information you wanted to share.
Thanks. I just have a couple slides, kind of a last-minute add-on. I think we were struck with the contrast between decreased 30-day readmission rates for heart failure and increased mortality. And so we want to make sure that whatever it is we're doing is appropriate for the patients and in the patient's best interest. As some of you know, I'm part of Virginia Heart, and we have a close affiliation with Inova Health and Heart and Vascular Institute. And we, because we have control of our patients, initiated a heart failure and AMI hospital readmission reduction initiative. And I only have a few slides. Just wanted to point out a couple things. The Inova system has a number of hospitals. We are active at 4 of the 5. And so this reflects some of those efforts. Much of our kind of Navigator approach is similar to what Mike had talked about. We have standardized heart failure order set. Inova, throughout its system, created a sprint system to drive cardiology consults and make sure that we were doing guideline-directed medical therapy. We have CHF navigators evolving with the plan to have at each of the hospitals to track the heart failure admits and to do manual assists and coordinating care. EPIC is our EHR, and there's some benefits to EPIC. We can create a daily report documenting all of the Virginia Heart CHF patients that are discharged within 24 hours that go to scheduling. And for all these patients on the list, we have a transitional care manager that's assigned. They'll do standard transitional services, including a 1-day phone call, checking the med list, symptoms check. And then we schedule the patients in the office within 3 to 5 days, and that order is in the EHR. There's redundancy for each patient on the list not scheduled for a visit. That same night, they receive a robocall, a text, and an email reminding them to connect with the office. And we have a rack card explaining the importance of why it's so critical that they come back to the office and comply with the medicine. And this is what that looks like. This is one of our physicians, and it's the post-hospital visits after a heart failure episode or heart attack. When do we want to see you? Within 3 to 5 business days. You will be seen by one of our experienced, usually it's one of the APPs, as the first visit. On the back, it has some of the questions that people commonly ask. Why do we need to be seen so fast? And how do I make that appointment? So they're provided this information. The way we looked at it, it's an evolving program. In the pilot in 2016, we had significant reduction in the 30-day, and I'm not sure how to remove that. So it was initially, 12 to 13% reduction. The way we, next slide. Oh, there we go. Okay, so we look at it sort of as your green light, yellow light, red light, and it's the OE, the observed over expected. This is for Fairfax Hospital, looking at our patients. And one of the points here is the more control you have over the patients, you have a tendency for greater success, although it just takes 1 or 2 patients and the numbers will skew for any particular month. This is for another one of the Inova hospitals, and the point of this is that although the trend is still, grand total is a positive OE or a lower OE, there's great variation. And so you can see there are months that were yellow, there are months that were red. And among the ongoing efforts to monitor impact, we have several things that we're doing. We're going to be tracking for outcomes. So it's not only reduction in hospital readmissions, but also what is the actual impact on outcomes, which is the holy grail, improving quality of life, lower cost, and keeping people out of the hospital and alive. We also have something that we call I need help, and each of those letters stands for something. We have advanced heart failure in the practice, and one of the things, if someone has more than one admission in a couple months, they automatically go to the advanced heart failure person to try to help. We also are tending to use, and we'll have to look and see what the actual impact is, but implantables, looking at helping to manage volume status to keep people out, and that on preliminary stuff seems to be helpful. So there are a number of initiatives that we've done. There's a long way we have to go. There's a great deal of variability, but those are some of the efforts that we've done, and we're extending it beyond the Virginia Heart patients to the rest of Inova Medical Group and the other patients. This is really just the patients that we've touched. So with that, were there comments or questions that, or added things that people wanted to add to it? Yes.
We use a community paramedic program. Have y'all used that in your area or at ECU, Mike?
Here.
Couldn't hear me. We utilize the community paramedic program for both of our programs, AMI and CHF, and what we find is that a lot of our patients trust the EMS paramedic, if you will. That has helped us decrease some of our readmissions, especially with our CHF group. The other thing that we do with our AMI group is we have what's called an H2O clinic, that's hospital to office. So within 1 week, we have a nurse visit for MI patients, which sort of helps with some of that explaining the medication. And we do have a pharmacist in our cardiology office that is very beneficial.
Yeah, I think that 1 week follow-up within the 1 week is very important for the patients, because I think they get hit with so much when in the hospital and they're not really comprehending a lot of the things, and I think potentially that can improve overall compliance with medications long term. I can see a lot of heads going up and down.
Yeah, we certainly strive for like the 3 to 5 day, and as Michael's data showed, there's a high percentage that are back in 3 to 5 days. So, you know, in busy practices, it's hard to get people in a week or 2 weeks, and we've really designated our APPs to be, and we have everyone's got great APPs as part of the heart team, and we're blessed with a bunch of folks that really get the patients in, get the time to explain things. We really try to tee it up. We also try to tee up cardiac rehab in the hospital, although as you know, for heart failure, there's a delay before you can get into rehab, but the AMI patients can go straight, assuming they're healthy enough, straight into rehab, and that helps. What are other folks doing? What are other communities doing that they've found successful? What we're trying to do is kind of figure out what are the best practices that we can then kind of look at the data and then share and extend across the Commonwealth.
We review, and Cindy, I couldn't hear you real well, so I hope I'm not just repeating what you said, but we in addition to the 3 to 5 day visit, we now review all of our readmits and chest pain counsel. Oh, thanks. So, you know, after we're done reviewing the STEMI cases and everything else, we carve out time to go over, okay, we had 4 readmits last week, you know, here's why, here's some fixable things, here are some unavoidable things, and we try to look for trends, and so it's really just kind of a case-by-case review.
We do that as well, and we have not really been successful because it's such a diverse group, and as Mike's data showed, the reason people come back is often completely unrelated to their index event. That's been a little disappointing.
We found a few opportunities, but yeah, I'm with you. It's so all over the map.
What kind of things did you find, Pete?
Well, you know, some of it, and some of it comes down to documentation. Just really educating. A lot of these folks aren't primarily even on cardiology services. We may have consulted, they may end up with us at one point, but part of it is education in terms of documentation. You know, the patients that are getting coded as non-STEMIs that are clearly, you know, if you look at the fourth universal definition, now it's even a little trickier. It's, you have your type 2s and you have your myocardial injury. So just trying to get all on the same page with that. But, you know, occasionally you'll find a breakdown in how the patients are getting medications dispensed, or you find a trend with the weekend discharges where you don't, try as you might, you don't tend to have the same comprehensive education and planning that you do during the weekday. But no, I'd like to tell you, hey, you know, we find that most of these are cardiology issues, and if we just fix them on the back end, we'll be okay. No, I mean, they fall and break their hip, they get home, they get confused, they develop some totally different problem that we don't have a lot of control over. Thanks.
How many of you are planning on doing bundle programs for either MI or PCI or heart failure? Just curious. I guess no one's taking that leap. Does everyone have, like, we're pretty far behind the times in some way. I think some hospitals are pretty good about having 1 or 2 appointments available for urgent cares for your potential readmissions, heart failure patients. Does anyone try to adopt that as a program to try to reduce admissions, or IV infusions while they're in the clinic? Or?
So what I'm hearing is you have an observation unit, you get people in, and you give IV diuretics, but they're not officially admitted.
Correct.
Is that correct?
That is correct, yeah.
What I would ask, you know, maybe go back to each of your institutions, and if, I don't want to really create work, but I think this is really a worthwhile endeavor, and maybe go back to the institutions and have someone write a paragraph as to what you're doing to reduce hospital readmissions for heart failure and for AMI, and then is it working? And then we can compile kind of what the different institutions around the state are doing and share that, and then we can figure out what's kind of working, what's not, what's best practices. So if you can do that and maybe send it to Eddie, and then we can, from the cardiology standpoint, put it together and then give it back to you all and figure out next steps. Any other comments, questions? So I guess we're done and we can move on to the next item on the agenda. We might actually...
You guys want to stay up here?
Sure.
Since it's cardiology related, and we might call on you for some commentary on the next slide deck.
Maybe we'll sit over
Or
there.
you'll see it better actually from the crowd. Okay, it's a good excuse. All right. So it sounds like we have some work to do with regards to monitoring AMI and heart failure readmissions, and we'll be putting out a query to you all for that. The one question I have is how do we monitor this data? I mean, it's not really in the CathPCI data set. Would we use outcomes from CMS, or how do we track this going forward? How do we know if we're getting better? Eileen?
Every hospital tracks their heart failure, AMI, their major readmission rates, because there's a penalty connected to it. And every hospital has publicly reported readmission, their CMS readmission data is part of Hospital Compare, because it's part of our penalty system. So it's out there.
Okay, but we have to get it from you
Yes.
guys.
Yeah, it's interesting if you look at least the CMS is public reported, but I think every hospital has the same question: where do your patients go that are readmitted? And at least looking at some of the national data, it's about 3/4 of MI patients will come back to your own institution for readmission. So about 1/4 will end up in another hospital. So there are some limitations in that. And I think it's primarily related to transfer patients who come in or have a home institution miles away.
It isn't there a lag there on the CMS data, and so that makes it very difficult, I think, to look at the data and analyze the data?
I think it's typically about 1.5 years behind when you get the total, so you do run those kind of limitations.
So thinking about that, going back to, asking your hospitals, are you tracking it? Are you tracking it more in real time than what you're seeing in the CMS data?
So ours is, you can see we've got, 2019 data, and we try to stay up on it and see if there are trends, see if we're falling down in an area. The other opportunity is VHI data might enable us, it will capture, assuming they're in Virginia, being admitted to a hospital in Virginia, we would be able to capture that information if they're being readmitted. Now, right now, we're asking for PCI, but we'll have the episodes, and that might be some area to investigate in the future.
It'd also be worth talking to VHHA because, it might be worth talking to VHHA because they have a readmission collaborative that's going on, and we get a report from them every month where they tell us what our readmission data is looking like. There's a lag to it, but they also let us know how we compare across the state. And for our hospitals, we look at the readmission results every month. So we have real-time data.
Thank you, sir. So to be continued, VHHA is a good idea actually as well. We've partnered with them, of course, for the inpatient financials. Maybe we could do so for readmissions too. So our next topic, and actually our last one of the evening, I get to play the anchor role here, is the updated look at our VCSQI cardiology metrics. So we have actually an update from ACE, our partner who does the angiogram reviews, and we'll look at some CathPCI data after that. So again, our strategic plan, we've reviewed this. Your CMEs, take a snapshot if you need to, and if you have any issues on those, let me know. We'll figure them out. I know this has been sticky in the past a little bit sometimes, but I think they've always come by. So, jumping into our cardiology, really our first cardiology QI project is with ACE, the Accreditation for Cardiovascular Excellence, and this came about a number of years ago based on the blinded review of cath films and trying to assess whether or not the angiographic images really are matching what is being performed on the patients. So Peggy, can I pass it over to you for a little bit of background on ACE? You're already ready? Perfect.
ACE is an accrediting body that looks at a variety of standards, and the standards have been developed through consensus development and reviewed and endorsed. And we take all of that information and look at procedures in catheterization procedures. So it's a procedure-based accreditation. So it's 10 years old. We've done over 150 accreditations or reaccreditations, and as a result, we have a lot of information to share, which has resulted in publications as well as presentations at various meetings, including ACC and SCI. So, should I share my exciting piece of news?
Yeah, go for it.
Okay, we just got accepted to participate in the technical expert panel for CMS to review and reevaluate inpatient claims-based outcome measures. So we will be doing that, taking some of the data that we have and lessons that we've learned. So.
Very good. We'll call on you to update us on that exciting project. Thanks, Peggy.
Sure.
In the meantime, we have some results from the angiogram reviews to look at. So basically the process is 5% of PCI cases are randomly identified, including at least 1 to 2 for each operator per center. Those are then uploaded, blinded, anonymously reviewed, and then sent back to us here at VCSQI, where the individual data is disseminated to each program, and then we look at that results together here. Thus far, we have 4 centers with completed reviews that we've seen, totaling about 160 patients, just about. We don't have to go through all of all the individual data points here, but needless to say, we look at number of lesions that are operated on, number of lesions that are treated successfully, and then lesions that are above or below 50%, and then whether or not that last category, the less than 50%, were successful or not. So for our 4 centers, the numbers are pretty similar in terms of success rates. In terms of the lesions that were under 50 operated on successfully, we're still at about 90%, but there is some room for analysis, I think, of those outlier cases. Dr. Shor, Dr. Kontos, any comment on our ACE results to date?
I think it's an interesting first look at how hospitals practice. I think the success rate is reasonably high. The smaller numbers, obviously with smaller numbers, you do run into the risk where 1 or 2 patients makes the percentage look lower than what you might expect if you're looking at a much higher volume number of patients.
I think the number of patients treated less than 50% is more than we would normally expect, and we'll need to drill down on that. I will say that I did have a conversation a week or 2 ago with one of the reviewers from Maryland, and they noted issues there as well. And so what we're trying to do actually is look at our data versus their data, and whether the percentages are similar. We're going to try to validate our process against their more in-depth and more costly methods. So there's a lot more to come. To make this successful, we need to have all of the participating sites participate and download the images.
I can suggest something too. We can take some of our data, I mean, we have data beyond just VCSQI's information, and see, we can take what we can that's similar and see how it compares to what we've done previously, which is considerably more in-depth than what VCSQI is doing. So it could give you the same sort of feel or look.
So let's talk offline. That would be an alternative validating method.
Right.
Pete, you were going to...
Just, can I ask a question? Thanks. So what's the definition of successfully or lesion treated? Does it mean attempt to wire, a device was activated? I'm wondering, is it, a handful of CTOs that they couldn't cross, or is it, hey, they stented it and the residual was 60, 70%?
I'd have to go back and check what your definitions were.
You know what I'm saying? Because that could explain the number if, I think 8% of lesions, especially if a center is taking on complex lesions, 8% may not be that far beyond what you'd expect, but I think once you balloon and stent to have more than 50%, that's pretty unusual. So I just didn't know what the definition was.
So we were defining, looking at images.
Sorry.
We were looking at trying to determine whether or not lesions that were intervened on, the stenosis was greater or less than 50%.
Okay, so they did cross, and they did something.
Right. Okay. So the question really is, and that was based on initially the culprit trial and then trying to find a number that would be reasonable for us. And if they were less than 50%, maybe they had FFR or some other measure that showed that they were more significant, but we didn't want it to be in a gray zone like a 70% lesion. So if it's less than 50%, there has to be some other, we would assume that you'd need some other validation of hemodynamic significance. And that really was a way of just making sure that people are intervening on appropriate lesions. And then the second question is, were they successful or not in their, whatever they were attempting to do?
I think the reviewer in this case, or these cases, have used their judgment to define what success is or not.
Yeah. And usually there's a note associated with it.
Correct. Yeah, there are comments on the individual cases most times, as well as to, especially for these the outlier cases, as to why it might not have been successful.
Right. So the main thing though for us in this was to make sure from a public safety standpoint that lesions that were appropriate as far as not insignificant lesions were being intervened on. and any outliers go back to the institution for their further review to determine whether or not FFR or something else was done. On the other hand, if they have an operator or several operators that are not adhering to appropriate standards, then you'd rather find out about it now rather than waking up and seeing it on the front page of the Post or the New York Times.
Which is why this is a mandatory process in Maryland.
Right.
In the
They
first
have a
place.
mandatory, unfunded process. So, and it's, the films are read between University of Maryland and Hopkins.
Chris?
I just had one question. I thought another statistic was very helpful when I first got my review, where you have the patients with the treated lesions less than 50%. Is it important to do the statistic of what percentage of all your lesions were less than 50%?
Yes. So that's supposed to be, in the data that we get, that's one of the key elements. You know, if it's 2%, 5%.
Right, because it's not shown here.
Well, you can do the math,
Yeah,
I think. So if total lesions were 252, and patients with treated lesions less than 50% were 27 lesions, so it's about 10%, a little more than 10% of the lesions. Is that am I looking at that correctly? So you can say it's about 10%, 22 out of 158 patients.
I'm just thinking for the reporting, it would be nice to see that. I mean,
Yeah, we'll correct the reporting,
Okay.
yeah.
Thank you.
Thanks, Chris. And again, these are really some of the first batches of reports we're getting back, so we can definitely add metrics like that. We have all the raw data from ACE, so we can really create any analytics from these reports that would be valuable, but we need your feedback too. There are 4 more programs, I think, right now who are being reviewed or in the process of being reviewed, so we should definitely have some more data by the next meeting. And if you're not participating,
I think
yeah.
there's one more hospital with 3 hospitals are also, so
Okay.
it's possible that we'll have 7 more.
Awesome. Well, the more the merrier, and if you're not on board yet, then we hope you you join in soon on this. Yeah.
Who are the 4 hospitals that are in?
I'm not sure if I'm allowed to identify them, but
There they are.
yes.
The individual institutions should have gotten or will be getting their information. Correct?
Correct. So
So, Ed, we participated in the first group, like 3 years ago,
Yeah.
but this is a whole new group. This is, these 4 are all new, not the same as 3.
includes the historical data, and we're adding in the new data as it comes in.
So I'm not ashamed, we're Inova, so we're in there?
Yeah.
Oh, okay. Yes.
Should have just asked you.
But it's old, it's like.
Correct. And so the hope is that, you know, the new data will come in soon, and we're working with you guys on getting that.
2018.
We're trying to do a rolling quarter, so different institutions, so they're not overloaded, but we're downloading, appropriate numbers.
Because our records have not been downloaded since that
Right.
original time, which was 3 or 4 years ago.
It was, yeah, 2016, I think, originally.
The 7 that we're doing now
Yeah.
and the 2 that are up there are all the same time periods.
Well, what is that time period?
2018,
See, I don't think we
So-
uploaded 28
well, you're,
Yeah.
records from
the
us.
2 new ones, not the 2 old ones, the 2 new ones, and the ones going forward, the 7 that we're doing now.
So this still includes old data that was on the screen, but going forward, we will do a better job of delineating the time frame and try to just show the latest information too. No, you're fine, Marian. Thank you. So going forward, we were attempting to schedule quarterly uploads for ACE. That's, again, an ongoing process. And I think we've already discussed how to utilize these. I think we just need to keep getting more data here.
So one of the things that I'm hearing is, a request from ACE is to make sure that we have timely reviews and ongoing reviews so that we have meaningful data coming back to the institutions, not old data. And so we just need to refine everything.
Next up, I wanted to do a review of our CathPCI data. As we mentioned earlier, of our 19 participating cardiology centers, 18 have sent cath data to us thus far. ARMIS has done a first round of matching with the VHHA, HIDE, and patient financial data. And so these are some of the results by year. They've gone back actually about 10 years. And you see a match rate here between 30 and 50% of the cases, which might look low to begin with. The caveat here is that the denominator this is all PCIs. Some of the PCIs, I think a good portion of them would not be in VHHA's database. So really we're looking at apples divided by an orange. If we normalize our denominator, which we had asked ARMIS to do, hopefully the next round they can do this. I'm hopeful we'll see a match rate at least above 50% here. I think it will be going forward with the VHI data. I think we can complement with some of the outpatient financials as well. But this is just kind of the current state of the union, which will get only refined as time goes on here. With regards to the specific clinical metrics we're looking at, all of these adhere to the standard ACC and CDR definitions. We're looking at the last 4 quarters worth of data, so going through Q2 2019. Our ACC Data Managers group has done a great job helping to refine some of these specs. But if you have questions, we've tried to delineate any tricky denominators and things like that in the graphs here. First chart just shows the overall PCI versus cabbage. This is any PCI versus any cabbage across our databases. So PCIs outnumber them over 2 to 1 based on the information we have. Looks like over the last about 6 quarters, they're trending pretty flat. I didn't go back farther than that because we don't have as comparable of data for all centers before that. But at least the last year and a half were relatively steady. Jumping into the metrics, these are blinded measures by hospital. They're grouped by volume. So our low volume is on the left, medium in the middle, high volume centers are on the right. The hospital codes are at the bottom here. If you don't know yours, let us know and we will identify you all. But again, everything is currently blinded as far as the group reports for cath. Our first look here is at vascular access site, femoral versus radial, and then there are a small proportion of others which we've excluded from this chart. But you'll notice, regardless of volume grouping, regardless of hospital here, it ranges from about 10% to over 90% radial access. So huge variation even within the last 4 quarters of data. Feel free to stop with any questions, comments.
I think that one of the comments that we'll look at the additional slides, which will be revealing. But I think when we're looking at disparities of care and potential impact on reduction of complications is reducing a variability of care. And what strikes me is, number one, that there is an increase in the use of radial compared to a few years ago, but there remains a huge variation. You have some high volume institutions that are 25% femoral and 75% radial, and you have one that's 80+% femoral and 15 to 20% radial. And I think we have, this highlights, I think, a real opportunity.
And going forward, we've broken down a number of the outcomes here by access site. This chart just shows for all patients in the VCSQI database about 9,000 or so PCIs. This includes cabbages as a caveat, so we're just looking at all comers here. But we've seen significant differences in bleeding, transfusions, mortality, and length of stay between the two access sites.
Now, one of the comments that we had talked about in a different meeting was that there may be a situation in the higher volume institutions that they're doing more femorals because the cases may be more complicated, or they may be sicker patients that for whatever reason femoral access is needed. But nonetheless, these are striking data. We'll need to look at this, pulling out those that go on a cabbage, because the issue of transfusion and bleeding event really might be influenced by whether they had surgery or not.
We can definitely pull those out. Regardless, looking at your high volume centers, some are 20%, 25%, others are about 90% in terms of femoral access, and the opposite for radial. So still tons of variation for that high volume group.
And clearly the radial group, for whatever the reasons, tend to do better.
So looking at some of the other outcome metrics by site here, this is RBC or whole blood transfusion. Again, all PCIs. Hopefully you can see the shade of gray there for the hospital bars, but this is an interesting one in the sense that the higher volume centers have higher rates. Again, these are non-risk adjusted data, so that might play a role here. And we also can compare against the VCSQI and the NCDR benchmarks. VCSQI is almost twice that of the national rate that we have.
We'll have to, again, pull out the surgical data.
Then when we split transfusion by access site and hospital, we see a lot of variation, but notice the scale on the left-hand side is 3 times as high for femoral versus radial. So it goes up to 15 in femoral, only 5% for radial, and even that, the highest site is less than 2%. For bleeding, this is all PCI cases. VCSQI is actually a hair lower than the NCDR benchmark. Still tons of variation across the board and within each volume grouping. Correct. So I believe this reflects the updated definition. Yeah. In terms of composite, this is death, emergency cabbage, stroke, or target vessel revascularization. We'll see this by access site in just a moment, but when we look at all cases, significant variation by, again, site and volume grouping. We need to get somebody like Scott to crunch these stats here, I think, for us. I take that nod as an affirmative. And again, when we slice it by access site, you see a lot higher rates in the femoral cases. Seems like less variation in the high volume radials. I'm not sure if that's just a small signal there, but and when we look at length of stay, this is total length of stay. I couldn't find the NCDR benchmark, but VCSQI was about 3 days. Some variation. It seems like the higher volume centers have a little bit higher length of stay on average. Could be, again, because of some of the trickier cases. But again, when we break it down by site, femoral is significantly higher across the board here. Cindy?
Curious with that higher length of stay, if that is increasing any readmission in those hospitals.
Speak up again with the microphone.
With a higher length of stay, I wonder if those hospitals' readmissions are decreased because the patient is there longer, more time to educate. I'd just be curious to look at that.
We've looked at that on the surgical side before, and there's almost like a sweet spot in the sense that if you discharge them too soon, or like one day they have a pretty high readmission rate, and then it dips, 3 to 5 days, and then it rises again after like 6 to 7. So. Right.
I'd just be curious, because that's a long length of stay.
That maybe when we have some of the readmission data coming back in, we can at least collate. We can't really link these together, but we could at least collate the averages against one another. I think one of the last ones we have is observed AKI by site. Again, this is all comers. Seemed to me like a very high AKI rate, even compared with surgery, a 7% rate across the state. I'm not sure. Was this a definition that changed recently too, or no?
No, that's right.
This is the same one. Okay.
This also points out another huge opportunity. As I looked at some of the data, it seemed that we were often, when we had NCDR data, we were fairly close, but this is one, or sometimes below. This is one of those that we're more than double. And this is to me is a real opportunity for us to focus on what are the institutions with low rates doing, what are the institutions with higher rates, what are best practices, and then see if we can roll that out. The American College of Cardiology just had a review on AKI prevention, and we may want to take that article, which was in the last month, and try to see if we can impact our AKI rate.
It's interesting because
When we started to look at this is a tricky indicator because in order to get in here, you have to have had the pre and post creatinine. So what we were finding is they weren't drawing the creatinines, so the denominator was low. So we started to look at that practice too.
it's interesting because it kind of foreshadows cabbage as well, because I think in the last year and a half, cabbage has had a high renal failure rate. We've seen...
It's not renal failure, acute kidney injury. It's
AKI, sorry.
Yeah.
Well, AKI, so...
Precursor there.
Yeah. Sorry.
Marianne was pointing out that the definition is incredibly stringent in the sense that it's a 0.3 milligram per deciliter rise in creatinine. So 0.9 to 1.2 could still trigger an event here. I'm not sure if our clinicians think that's a technicality or not, but it gets flagged here regardless.
I know at institutions, we've had discussions, and when do you get that pre-lab work? After they've been pre-hydrated and you're about to stick the artery, that's where you get your creatinine, and after patients have been hydrated and the whole thing. So, yeah, your point about whether even post numbers are checked is an interesting thought, and I wonder how many of the numbers that we have, what percentage this actually reflects that we have all that information.
Have you seen differences with, did they draw a lab or did they do an ISTAT? I mean, there's all kind of little nuances to go into this that we're investigating.
Keep us posted.
Regardless of definition, seems like an opportunity here. As far as AKI and a number of the other metrics, access site that we had mentioned. Marion?
No, I'm sorry. Linda had asked questions. I'll be good.
No, you're fine. If you'd like to share, you're more than welcome.
I think it's interesting what you guys are saying.
Yeah.
Oh, Linda was asking.
I was asking about definition because in surgery we have a pretty strict definition about what lab we take for that pre-op creatinine. It's the closest, absolutely the last one before the patient goes to surgery.
Right, but in likelihood, if you're coming in for a PCI,
Your PCI patients are going to be outpatients, most of them, and that lab is going to be drawn before they even come in the hospital. So that's number one. So the second thing is that it's a prescribed time afterwards. It's within for the creatinine, for the rise, for the post.
Yeah, and ours
But
is
it
the
can
first
be a
one.
lab or it can be a ISTAT. It doesn't matter. I mean, it doesn't, the definition doesn't make it matter.
But in practice, it makes a difference. When
Right.
you draw them at the same time, and the results are different.
So do you just not draw it?
But if you don't draw it, the denominator, so it's,
It's
you
sad.
just have to look at what's the best way to take care of the patient.
Yeah. And the numbers are what they are.
Sorry, Stan, do you want to share?
No, we were just talking.
Okay.
When do you draw the labs? We were just talking about when do you draw the labs, and we get the same thing with TAVRs, with the hemoglobins. It's almost like we start playing the lottery, and we just got to take care of the patient and forget all the rest of it. Of course, my COO probably won't say that, but anyway.
Fair enough. Well, it definitely seems like there is a data consistency. I won't say an issue, but a potentiality here to investigate, because some sites might be measuring it differently, and that could even explain a difference from the national rate. Other questions or comments with regards to the cath data that has been presented, any of the ACE information? I just wanted to note here right now that our CathPCI repository houses more than 60,000 PCI records and growing. It's over half the size of our cardiac surgery database already. So there's a lot of potential. It's ripe for bright young researchers, Robert, Scott, like you guys, to get in and mine the data. And anyone else who has an idea, any research questions you might want to ask of us. This is, again, your data, so opportunities abound in terms of the financial data, the outpatient records that were coming in, and ultimately at the end of the day, how we take care of our patients here. So your ideas are welcomed, encouraged, and we need them to move forward here as part of the VCSQI's mission and vision. So, questions, comments, thoughts? I think we're running early for a change here. So, Dr. Shor, do you have any closing comments?
No, I just think this is great. I think the discussion was fabulous, and it points out we have a lot of opportunities. I really look forward to getting more data that we can start drilling down and working on best practices. Very exciting, and we really want to get the feedback from all of the institutions, hospital readmissions, what you guys and gals are doing, and figure out what we can do for AKI and access and issues like that. So any particular areas of interest that you want us to look at the data, we want to be able to make this user-friendly and of value to everybody. So thank you for coming out on another evening.
Thanks, all, and happy holidays.